You're completely awake. Someone is about to cut into your leg with a knife, and there is no anesthesia, no painkiller, no hypnosis that's going to stop you from feeling every second of it. Your only job right now is not to move. This wasn't a nightmare. This was just Tuesday for almost the entire history of human medicine. Think about the worst pain you've ever felt: a kidney stone, a broken bone, childbirth. And now take away the epidural, the morphine, even a children's ibuprofen. Nobody is hurting you by accident. Someone is about to hurt you on purpose, to fix you.
So today, we're asking the question nobody wants to think through to the end. How did people survive being cut open, stitched up, and operated on, fully conscious, feeling everything? And what does the answer say about exactly how much pain a human body can absorb before it simply can't anymore?
30 seconds. Let's start with the simplest, oldest answer: speed. If you can't kill the pain, the next best thing is to shrink the amount of time someone has to feel it. By the early 1800s, surgery had basically become a sport of speed, and the undisputed champion was a Scottish surgeon named Robert Liston. He worked in London, and by every account from people who watched him operate, he was terrifyingly fast. His signature move was amputating a leg above the knee in under 30 seconds. Knife in one hand, saw already moving before the assistant had even finished tightening the tourniquet.
There's a story about Liston, still retold in medical schools today, where he supposedly moved so fast during one amputation that he took off 2 of his assistant's fingers, along with the patient's leg. And, according to the same story, a spectator in the room dropped dead from shock just watching. Historians argue about how much of that's exaggerated. What nobody argues about is that Liston's reputation for speed was real, and that speed, not gentleness, was the single most valuable trait a surgeon could have. Why? Because every second a patient spent on the table, conscious, was a second where the body could go into shock, where blood loss could turn catastrophic. The sheer trauma of being awake for an amputation could be more dangerous than the amputation itself. A fast surgeon wasn't showing off, he was practicing harm reduction with a blade. But speed only solves the problem for procedures that fit inside 30 seconds. For everything else, doctors needed something the knife alone couldn't give them.
The sleep sponge. So they reached for chemistry, or the closest thing to it that existed: opium, mandrake juice, henbane, alcohol in genuinely alarming quantities. These weren't desperate folk remedies. They were real, pharmacologically active substances.
The most famous delivery system was something called a soporific sponge, used across medieval and Renaissance Europe. Surgeons soaked a sponge in a mixture of opium, mandrake juice, and sometimes hemlock, then let it dry. Right before surgery, they'd re-wet it and hold it under the patient's nose. Breathe it in and you'd drift toward unconsciousness, or at least toward not caring very much about what was happening to your leg. Here's the part that should make you slightly uneasy. The dose that worked and the dose that stopped your heart were uncomfortably close together. Get it right, and the patient came out groggy and confused. Get it slightly wrong, and the patient simply never woke up at all. Technically, also solving the pain problem, just not in the way anyone wanted.
Faint on purpose. One of the backup plans for when the sponge wasn't enough sounds like a joke until you realize how seriously it was used. Bleed the patient first. Before certain major operations, surgeons would deliberately draw blood from the patient, not to treat any disease, but specifically to push them toward fainting. Someone who's lost enough blood to lose consciousness doesn't feel a scalpel the way a fully alert person does. It sounds reckless because it was reckless. Doctors were literally weighing 2 different ways a patient could die and picking whichever one seemed slightly less likely that day. This wasn't medicine failing. This was medicine succeeding by the only standard that existed.
Bite down. For patients who stayed conscious anyway, the next line of defense was the mind itself. In the 1840s, a Scottish doctor named James Esdale, working in India, started using mesmeric trance, an early and controversial form of hypnosis, before surgery. He documented hundreds of operations where patients showed little to no visible pain response under that trance. Nobody at the time, and honestly nobody today, fully agrees on the mechanism, but the documented results were striking enough that Esdale kept doing it, case after case. For anyone without access to a mesmerist, there was a cruder version of the same idea, biting down, hard, on a leather strap, a block of wood, or if you were a soldier in the field with nothing else available, sometimes literally a bullet, which might be where the phrase "bite the bullet" actually comes from, though linguists still argue whether that's the real origin or just a satisfying coincidence. Clenching your jaw with everything you have does activate real pain-modulating pathways in the body. It's not nothing. It's also nowhere close to enough.
The body's own drug. Now picture being the surgeon for a second, not the patient. You're holding a blade over someone who feels everything, and the only thing keeping the operation from turning into chaos is whatever that body decides to do on its own in that moment. Because here's the strange twist. The human body actually comes with a built-in emergency painkiller. It's called stress-induced analgesia, and it's the same mechanism behind soldiers in battle who take serious wounds and don't even notice until hours later when someone points out the blood. Acute trauma triggers a flood of the body's own opioid-like chemicals, numbing pain just long enough to fight, flee, or survive the immediate crisis. The problem is that this system is built for sudden, chaotic danger, not for a calm, deliberate, hour-long surgery. Your body's free internal anesthesia is excellent for being mauled by a predator. It's almost useless for lying still while someone methodically saws through a bone.
Worse than the cure. This is where the story stops being fascinating and starts being genuinely brutal. Pain itself could kill you on the table. It's now understood that severe enough pain and shock can, on their own, crash blood pressure to fatal levels, separate from blood loss entirely. Surgeons of the era didn't have that vocabulary, but they recognized the pattern. Patients who died not from the wound, not from infection, but from the sheer overwhelming experience of the procedure itself. That's also why so many surgeons simply refused to operate, not from lack of skill, but because they'd calculated, correctly, that the patient was more likely to die of the pain than of whatever was being treated. Tumors never removed, hernias never treated, broken bones left to heal crooked because setting them properly demanded more conscious suffering than anyone thought a body could survive. The real death toll of pre-anesthesia medicine isn't just the people who died on the table, it's everyone who never made it to the table at all because surviving the cure looked worse than the disease. Speed, sedatives, induced fainting, trance, sheer willpower. None of these alone were enough. Stacked together, scraping the edge, they were just barely enough to call it medicine.
The Silent Room. Then, on October 16, 1846, in an operating theater in Boston, still called the Ether Dome today, a dentist named William Morton administered ether to a patient named Edward Gilbert Abbott, right before surgeon John Collins Warren removed a tumor from his neck. The room was packed with doctors expecting the usual: screaming, restraint, blood, chaos. Instead, Abbott lay still, calm. The operation finished, and Warren reportedly turned to the room and said, "Gentlemen, this is no humbug." The crowd didn't applaud, they just sat there, processing what they'd actually witnessed. Because for the first time in the entire recorded history of surgery, the room had gone silent. That was less than 200 years ago. Out of the entire span of human medical history, the part with no screaming is a thin, recent sliver right at the end. A 10.
So somewhere in your bloodline, there's an ancestor who needed a wound stitched, a bone reset, or a hard birth resolved with nothing but a leather strap, a questionable sponge, and someone holding them down on the floor. They survived it, or you wouldn't be here reading the sentence. And if they hadn't, if the dose had been a little too strong or the surgeon a little too slow, that line simply ends, quietly, a few centuries before you were ever a possibility. So next time a nurse asks you to rate your pain from 1 to 10 before giving you a shot that makes the whole thing vanish in under a minute, remember what a 10 actually used to mean. It meant a knife, a stranger's firm grip, and absolutely nowhere to run.